The title of this talk is largely add-on therapies. These are my relevant disclosures again, and some irrelevant disclosures. So here we are again, several hours later, a ton more information, but I'm going to go back to that core that I presented earlier, that pathophysiology, where we see on the left the vegetative phase, the phase that causes symptoms. We've heard a very nice presentation from Kevin Gary, some other presentations talking about how those antimicrobials can target that vegetative phase, keep it under control. But we still do have lots of recurrences. We've heard about antimicrobials that might decrease those recurrences, the pharmacobiome, et cetera. But there's currently add-on therapies that we could consider, and there are things coming in the future. And that's what we see on the right-hand side of this slide. The right-hand side of the slide, as you'll remember, is this portion of the slide where the vegetative phase is releasing TCDA and TCDB, the toxins, stimulating that diarrheal syndrome. The first level that I want to talk about is the level of the toxin itself. And we've had allusions to bezlotoxumab today. Let's talk about a little bit more detail. Bezlotoxumab is a fully humanized monoclonal antibody that binds toxin B in a specific way. It is given or was given during standard of care antimicrobial treatment. The data for bezlotoxumab came from two parallel studies with the lead author of Mark Wilcox, published in 2017 in the New England Journal of Medicine, the Modify 1 and Modify 2 trials. Prospective, double-blinded, randomized, placebo-controlled trials of patients with C. difficile and recurrent C. difficile. Those patients were given standard of care antimicrobials and randomized in Modify 1 to an infusion of placebo, an infusion of bezlotoxumab, an infusion of actuximab plus bezlotoxumab, or an infusion of actuximab alone. What is actuximab, or what was actuximab? Actuximab was a fully humanized monoclonal antibody to toxin A. It didn't work as well as we would have expected, so it was largely left by the wayside after the trials. What we're going to focus on is the difference in 90-day recurrence between an infusion of placebo during standard of care and an infusion of bezlotoxumab. In Modify 1, we saw a 28% recurrence rate for placebo, 17% for toximab. In Modify 2, 26% at 90 days for placebo, 16% for bezlotoxumab. It was these parallel clinical trials that led to FDA approval and the first major breakthrough for add-on therapies to prevent future C. difficile recurrence. We'll fast forward to after the pandemic. Colleen Kelly's study group did a very, very nice job. They said, look, during the pandemic, we really didn't have access to fecal microbiota transplant outside of clinical trials. So what moved into its place temporarily? Bezlotoxumab. So there was a bunch of data that came out after that. Here we're looking at 13 total studies, 2 randomized controlled trials, Modify 1, Modify 2 that I just showed you, 2,337 patients. Recurrence rates in the group that received bezlotoxumab, 15.8%. Recurrence rates in the group that received placebo, 28.9%. So we see bezlotoxumab very, very effective. There was one safety signal that we were mindful about. That was in patients with congestive heart failure. Within Modify 1, Modify 2, there was an increased risk of CHF exacerbation. So patients that had moderate to severe CHF, this was not a good treatment. But unfortunately, on December 23rd, 2024, we received a bag of coal. This was being removed from the market. In the comments section, we had a number of theories for why it was removed from the market. The one thing that I will say about this that I know definitively is it was safe, it was effective. Merck unfortunately had to make a challenging decision, and there was a ripple effect. We had one significant technological advancement that is not currently available to us and our patients, but there is future hope. A little while ago, we heard about AZD5148. This is a next generation approach to binding toxin B. We heard that this is incredibly effective, and in fact, there are trials that show that this binds to 99% of the toxin Bs that we will see from C. difficile, compared with about 82% with bezlotoxumab. Another bonus with this molecule is that it lasts 180 days, not 90 days. So we're talking about 6 months of management versus 3 months of management, giving more time for the microbiota to restore and lower rates of recurrence. Obviously, that's all theory. We know we have phase 1 data, phase 2b PRISM study coming. So hopefully over the next couple of years, we will see that information. What other add-on therapies do we have? We've had multiple allusions to this. We had a lecture from VE303 or covering VE303 just before this. This is fecal microbiota transplantation. So let's talk about what we're doing with FMT, or as I like to call it, microbiota restoration therapy. Here on the left, we see the vegetative phase. We are treating it with antimicrobials. On the right, we see the spore phase. We need a healthy, diverse microbiota with supplementation of Bacteroidetes and Firmicutes to prevent future recurrence. So fitting this into the pathophysiologic scheme that I presented earlier this morning, we see that reconversion of the vegetative phase to the spore phase. The spore phase hangs out like a spy. We do not want it to reconvert to the vegetative phase and cause a recurrence. So by supplementing that microbiota overnight, not allowing the body time to regrow, but actually supplementing it quickly, much less likely to have a recurrence. That's the theory, and that's why the guidelines recommended that we use this, I'll say earlier now than in the past. Historically, this was recommended for second recurrence and beyond. February of 2024, we have the American Gastroenterological Association updating their guidelines, essentially saying that this should be used in patients at greatest risk for future recurrence. Kind of a subtle way of saying first recurrence and beyond in those at greatest risk. So multiple risk factors for recurrence. But they also said that patients who are immune competent, patients who have a normal immune system, can receive either old school FMT or the more modern FDA treatments. For those who are mild to moderately immune compromised, they said that the FDA approved treatments had insufficient evidence and we should just use the old school FMT. Post-dating this publication, we do have some data, and I will show that to you from one of the FDA-approved products that shows efficacy in those who are mild to moderately immune compromised. And most of us in the field feel comfortable using these products, the FDA-approved products, in those who are mild to moderately immune compromised. In those who are severely immune compromised, we should not be using any of these treatments for risks of sepsis. So let's talk about the data. And I still believe that the best data available looking at microbiota restoration therapy for the prevention of recurrence of C. difficile came from this meta-analysis published in 2023 from Racine Tariq, Sahil Khanna, and Daryl Pardee. They said, look, let's take a look at all of the prospective data. We have a lot of retrospective data, but we know that that retrospective data is limited. So let's look at just the prospective data. They looked at 19 trials, 1,176 patients, and they showed an efficacy of 78%. Now, I want you to take a step back and remember Majdi Osman's presentation where he looked at 10,000 patients, give or take, who received open biome. The efficacy there was 79%. Now, these are prospective trials. That was more of a retrospective analysis. But the bottom line is we're in the 78 to 79% efficacy in open label type formats. What about randomized controlled trials? This beautiful meta-analysis looked at that as well. There were 10 trials, including trials that looked at FDA potential products at the time. 10 trials, 523 patients. The efficacy was 72%. Would, of course, expect in a randomized controlled trial that the efficacy goes down a little bit, and that's, in fact, what we see in practice. But what we've learned, unfortunately, is that open biome is no longer available. So we largely have to focus on the FDA-approved forms of microbiota restoration therapy. And I want to compare and contrast here, starting with donor screening. And no, this is not how we used to screen the donors. What we used to do was, in fact, I'm going to use Yale as an example. What we did was we would have donors come donate on the day of the procedure, but they'd have to get through a clearance process. So they would come the day of the consultation, and on the day of the consultation, we would take them into a separate room. If it seems like the patient was indicated for microbiota restoration therapy, we'd take a history. If they didn't have any of those risk factors that we considered transcribing through the microbiota for various diseases, we would then check their blood work and stool studies. We check them for hepatitis A, B, C, HIV, syphilis. We would check their stool for culture, ovum parasites, C. difficile, Cryptosporidia, Isospora, and Cyclospora. If they were negative for all of that, we said, you're good. Okay, pass through. The FDA-approved treatments, much more comprehensive assessments on the samples that are going into the treatment. We were predating the donation and assuming that over the weeks or days between the sample testing and what was donated, we assumed that it would stay consistent. Next, sample screening. So what do I mean by sample screening? What I mean is, if I were to tell you I have a treatment, it works about 78, 79% of the time in prospective open label studies. We have no clue what's in it. And every single time we use it, it's different. Would you use it? Well, of course we would. We used it for years. Best available knowledge at the time. The FDA-approved treatments, though, the FDA-approved treatments have known defined consortia. We understand what's in them. There are bands of quality associated with them. So kind of a plain different approach. Not saying that old school FMT doesn't work, but I'm just saying we don't fully appreciate what we are administering. Next, let's talk about good manufacturing procedure. As I mentioned at Yale, we had to have an IRB, Institutional Review Board approval for our procedure. So when I put it through the IRB back in 2013 initially, and then repeatedly year after year, we were required to have the donors come donate on site. Now you're saying, well, why? Because there were reports nationally of people bringing in not their own stool and non-human stool. So the yuck factor goes through the roof. This is our primitive setup. This is from the first FMT that we performed under enforcement discretion at Yale. We see this was done right in the endoscopy suite. This isn't a lab. This isn't good manufacturing procedure. It was best available at the time. We would have the donor come donate on site. We would take 100 grams of stool. We'd blenderize it into 300 cc's of normal saline. We'd sieve it through a polyp retrieval kit, removing the fibrous matter so that we can inject it better through the endoscope or through the colonoscope. We would give loperamide before the procedure. We'd inject about 300 cc's into the right colon, pray a little bit, and it worked quite well. Was it clean? Well, we're dealing with stool. Not really. Was it under good manufacturing procedure? No. FDA-approved products, good manufacturing procedure. Open biome, good manufacturing procedure. So a different lane. What about the clinical trial data? As I'm going to show you in subsequent data that I'm going to present, the clinical trial data for FDA-approved treatments, certainly more rigid and better designed than the old school FMT. Safety data, similar. We need to think about it as we had retrospective safety data for old school FMT. We have prospective safety data for FDA-approved MRT. Now, ease of access. And ease of access is something that is a challenge and has been a recurring theme today. We know that open biome is no longer available. Therefore, we have to rely on the FDA-approved treatments. Now, as I start to shift over and talk about the data behind the FDA-approved treatments, it's important to understand that when I say placebo, these patients aren't just receiving a placebo. They're receiving antibiotic followed by either placebo or the intervention, the microbiota restoration therapy. And the first treatment that I want to talk about today is fecal microbiota live, JSLM, trade name is Rebiota. We will refer to it as RBL. This is a broad consortium of microorganisms, so a wide array of microorganisms, including both spore and non-spore forming bacteria. There's 10 to the 7th microorganisms per cc. It is administered as a single rectal installation. It takes about a minute or so to administer this. This is the data behind RBL. This is the PUNCH CD3 trial, prospective double-blinded randomized placebo-controlled trial of patients with first recurrence and beyond, diagnosed at the discretion of the local investigator. All diagnostic assays were on the table for this test, so mimicking real-world practice. Patients had at least 10 days of standard of care antimicrobial. They had a washout period where they received no antimicrobials to allow the patient to defecate out the antimicrobial matter. And then they were randomized to either receive RBL or placebo, followed for 8 weeks for recurrence, 24 weeks for safety. Overall efficacy of RBL through a Bayesian analysis was 70.6% versus 57.5% in the placebo arm. The posterior probability of superiority was 0.991, a significant difference, and this was significant contributing data to why this product was approved by the FDA. At the end of the day, though, we're learning about basic science here, and my talk is largely clinical, but this is where we can geek out a little bit on the basic science. Here we see the changes to the microbiota associated with RBL in RBL-treated responders and placebo-treated responders. We see with the RBL-treated responders, we have a quick bump in the Bacteroideae and Clostridia and a decrease in the gamma proteobacteria and bacilli. Those changes explain the physiology of prevention of recurrence. But we've heard a lot about bile salts. I introduced it this morning, and I hope I didn't overwhelm, but we've heard it repeatedly. Remember, primary bile acids bad. So here on the left, red bad, blue good. Secondary bile acids good. Weeks 1, 4, and 8 after administration of RBL, a lot more blue than red. This explains why there's lower rates of recurrence. Side effect profile includes abdominal pain, diarrhea, distension, flatulence, and nausea. These were short-lived, mild to moderate in nature. Let's now talk about data from this year. The largest open label study, the largest study considering microbiota restoration therapy, was published in Clinical Infectious Disease earlier this year. It looked at 676 individuals with at least one recurrence of C. difficile infection. The beauty of this trial was that it included a lot of the groups that we've asked questions about today. Patients with irritable bowel syndrome, patients with ulcerative colitis, patients with Crohn's disease, patients who are immune compromised. So it included real-world populations so that we can relate the efficacy of this product into those patient populations. Overall efficacy at 8 weeks was 73.8%, and of that 73.8%, 91% remained responsive at 6 months. So it was consistent with the pivotal trial, but now let's take a look at those subgroups. And let's first talk about inflammatory bowel disease. As a gastroenterologist, this is an important patient population for me. 71 of the patients within this open label study, so a sizable group, had IBD. The overall efficacy was 78.9%. 78.9% of those patients who had IBD remained responsive at 8 weeks. The efficacy within a Crohn's disease cohort was 80% at 8 weeks versus 76.2% in those with UC. But the bigger question is, they responded. Did they remain responsive at 6 months? The answer is yes. 91.1% overall efficacy, sustained efficacy in the IBD population, with an 85% sustained efficacy in Crohn's disease and a 96.9% sustained efficacy in those patients with ulcerative colitis. So it seems safe, it seems effective, and there did not seem to be exacerbations of the IBD. What about that immune compromised population, that population that the guidelines from February of 2024 said insufficient evidence? Here is your sufficient evidence. We had 140 patients with mild to moderate disease within the open label study. Overall efficacy at 8 weeks was 75.7%, and of those, 88.7% remained responsive. No concerning safety signals seen. So how is this actually administered? I mentioned it's a single rectal installation. There is a bag, a tube, and a clip. Essentially, patients who receive an add-on therapy, microbiota restoration therapy, they should be asymptomatic. Therefore, they should not be significant infection control concerns. They should be able to come to the office. This can be done in any exam room. We gown them up like any rectal exam. Comes with a bag, a tube, and a clip. We put Surgilube on the tube. We insert the tube into the patient. We open the clip, and it takes about 60 to 90 seconds to administer. Now, Dr. Sahil Khan is going to be speaking, I think, just after me. He's going to cover the colonoscopic application of RBL and that super exciting data showing 95% 8-week efficacy and 92.7% overall 6-month efficacy. The question about this was alluded to earlier. We have 2 publications from just this year where he was the lead author. Next, the other FDA-approved product, fecal microbiota spores, live BRPK. Trade name is VOWST. We will refer to it as VOS. Here, they say, look, we don't need to give everything. Why don't we just give Firmicutes spores? So it's administered as 4 capsules daily for 3 days. There are 3 times 10 to the 7th colony-forming units per total administration. Their pivotal trial, a bit of a different approach. Prospective, double-blinded, randomized, multi-centered, placebo-controlled. But here they included second recurrence and beyond. And here the diagnostics included cell culture, cytotoxin neutralization, and enzyme-linked immunoassay. A pure patient population, minimizing the false positives. All patients received 10 to 21 days of vancomycin or fidaxomicin, the washout. But here, there was a gentle bowel lavage, 10 ounces of magnesium citrate. And then patients were randomized to either capsules of VOS versus placebo, followed for 8 weeks for recurrence and 24 weeks for safety. Overall efficacy of the VOS supplemented group was 88% versus 60% in the placebo arm. Did the science fit? A resounding yes. These are figures from the New England Journal of Medicine publication. On the left, we take a look at Firmicutes, which is what this product is. The Firmicutes increased at weeks 1, 2, and 8, significantly higher than the placebo arm. The placebo arm, we see that general natural growth pattern, but the group that received VOS boosted it up immediately. What about the bile acids? Secondary bile acids significantly higher at weeks 1, 2, and 8 with VOS versus placebo as well. Adverse events or side effects, nothing worrisome here either. We have distension, fatigue, constipation, chills, and diarrhea. Mild to moderate nature, short-lived. The open label study here took a different approach. They said, what about first recurrence, and what about including the PCR assay? So they made it more clinically applicable, although there weren't those subgroups that the other trial that I quoted looked at. Here we had 263 total patients. Portion of them rolled over from the pivotal trial. Another portion directly entered with the PCR assay and first recurrence, widening the inclusion criteria. Overall efficacy was 91%. For first recurrence, 94% at 8 weeks. Second recurrence and beyond, 90% at 8 weeks. and the sustained effect was 86%. So how do we do it with VOS? With VOS, similar to the other, except patients don't have to come to the office. They're taking pills. So I give sustained antimicrobials until they receive the product. They have the washout. They take a gentle bowel lavage. And then they take the VOS on an empty stomach, 4 capsules daily for 3 days. We just had a very detailed discussion about VE303, so I'm not going to go into any more detail. And we specifically discussed this specific trial and its positive effects. I'm super excited to see what the phase 3 looks like. I will warn everybody who's participating today not to compare and contrast any of the pivotal data. There are significant differences between the trials. We need to take a look at everything in totality. This is just a simple table comparing some of those differences. So if you try to compare them, you're comparing apples to oranges to bananas. The discussion that we have with our patients is important. We need to outline what the methodology is of administration. Is it an enema formulation? Is it capsules? We have to talk to them about what the pivotal trial looked like, who was included, but more importantly, what that side effect profile looks like. We should be talking about whether it's a broad consortium or a narrow consortium or a defined consortium if VE303 eventually makes it into the clinics. These are all important points to discuss. So in conclusion, we are at an absolutely exciting time for C. difficile. We've made a ton of progress, but we've gotten hindered a little bit. Bezlotuximab, great progress, no longer available, but we have AZD5148. Right now, we have 2 FDA-approved products available, but unfortunately, Open Biome is no longer available. So we have to use what is available to us, and I think what's available to us is super exciting. We've heard about VE303, potentially that next generation. We've heard about the next generation in antimicrobials. And I think something else that hasn't been mentioned today is fidaxomicin did in fact go generic this year, and we're just waiting to see what the pricing looks like. So that shift also can help hopefully gain access to patients for what I believe to be a superior therapeutic. With that being said, I'm going to say thank you so much for your attention.